Welcome to Compass Opioid Stewardship in Practice. Each week, our Compass coaches will explore a real-world case, define a clinical goal, and walk through practical strategies to improve care. Whether you're tuning in via video, audio, or reading the summary, this session is built for busy clinicians like you. Enjoy the show.
Hi there, my name is Dr. Joshua Bloom. I'm a primary care internal medicine and addiction medicine physician and coach in the Compass Opioid Stewardship Program. This week's case is part one of a two-part series on urine toxicology testing. Let's start with the case. Tania is a 37-year-old female with chronic pain from lupus vasculitis and peripheral neuropathy. She has episodes of severe abdominal pain and describes intermittent electrical sensations in her legs and feet. Medications include hydroxychloroquine and azathioprine for lupus, duloxetine and bupropion for depression and pain, and meloxicam, gabapentin, and lidocaine patches for pain. For severe episodes, she uses hydrocodone and acetaminophen 10 and 325 milligrams, 1 to 2 tablets every 4 to 6 hours, and is prescribed 84 tablets every 28 days. She fills this medication on time every 4 weeks and has never requested early refills. We'll use Tania's case to discuss the pros and cons of urine toxicology testing, how this intervention may augment patient safety, as well as potential harms of testing. We'll also review some of the expert guidelines and talk about steps that can be taken to mitigate and prevent negative impacts to your relationships with your patients. In the second episode, we'll dive a bit deeper into specific testing strategies. So urine toxicology testing can be a controversial monitoring intervention for patients on chronic long-term opioid therapy. Testing has two main objectives. First, to confirm the presence of the prescribed medication and the absence of other illicit substances in order to ensure safety. On the one hand, studies have shown that testing routinely uncovers unexpected results and evidence of other substance use that may put the patient at risk for severe outcomes, including opioid use disorder and overdose. An older study by Katz and colleagues found that systematic testing identifies twice as many patients with unexpected substance use than would be picked up by surveilling for behavioral issues alone, such as requests for early refills or unsanctioned dose escalations. And additional evidence confirms that other substance use predicts future opioid misuse. On the other hand, urine toxicology testing can be a fraught intervention, with providers often not understanding the limits of their testing strategies and taking a confrontational approach to discussing unexpected results. For instance, in a famous study of training physicians, many had inflated confidence in their own ability to interpret results despite clear knowledge gaps. This can result in accusations and unilateral decisions to change management based on incomplete or even faulty information, and this may irrevocably disrupt the patient-provider bond and cause other harms. When used inappropriately, an unexpected result may be seen by a provider as a gotcha moment and an opportunity to immediately discontinue opioids, or worse yet, to summarily dismiss a patient from practice. Because of this, the 2023 updated CDC opioid prescribing guidelines recommend that prescribers should, quote, consider the benefits and risks of testing and affirm that results should be discussed in a non-judgmental manner, highlighting safety concerns. Taking things a step further, the 2022 Veterans Affairs and Department of Defense guideline state that urine drug testing is required to initiate or continue long-term opioid therapy. Both guidelines note that patients should be verbally consented to testing and should be instructed that testing will not be used to dismiss patients from care. Finally, providers should avoid using stigmatizing language such as clean or dirty when discussing results. In my practice, I often initiate a conversation with the patient by reviewing the unexpected result and asking the patient to help me understand this. It's important to keep in mind that a urine toxicology result is not a diagnosis and gives an incomplete picture of what's going on in the patient's life. It's up to us to elicit additional information for a fuller picture and to understand if changes are needed to the patient's regimen or monitoring approach to ensure ongoing safety. So let's finish with some takeaways and clinical pearls. Urine toxicology is something done for the patient, not to the patient. Apply your testing strategies to your practice universally. This doesn't have to mean testing everyone equally frequently, but consider using a risk tool to objectively stratify patient risk in determining testing frequency. Don't ignore unexpected results and follow up with your patients as quickly as possible. And finally, and maybe most importantly, use non-judgmental language and open-ended questions when discussing unexpected results. Remember, urine toxicology is not one of the criteria we use to diagnose opioid use disorder or other use disorders. It's up to you to elicit a more comprehensive patient history and not to jump to conclusions.
This show has been brought to you through the generous support of the Centers of Medicare and Medicaid Services. Thanks for joining this week's Compass Opioid Stewardship in Practice. Thank you for being part of the Compass Opioid Stewardship Program, and thank you for all you do caring for your patients. See you next time.